Our next speaker is Courtney Kokenakes, who I have the pleasure of working for the last several years. She's a tremendous expert in the world of genetic counseling. You and I just talked about genetics and genomics and what that means, and yeah, maybe a good 5% of the room raised their hand. So Courtney can only be upwards after you're done with your discussion. And this is a conversation ongoing. And if we're going to take one thing home today, it's really to remember what she's sharing with us, because this is how we spread the word, how you share your voice with the communities around you. Courtney Kokenakes.
All right, good morning, everyone. My name is Courtney Kokenakes, and I'm a genetic counselor with Karmanos. I've been with Karmanos for 7 years, and today I'm going to talk with you all about the role of genetic testing in cancer risk management. So genetic testing, I know not a ton of people raised their hand when Dr. Heath brought that up at the beginning, so just in kind of a nutshell, genetic testing is a DNA test that can help tell you if there might be something hereditary running in the family, potentially causing cancer or putting people at a higher risk for cancer. So today we're going to talk all about what that testing entails and how somebody can use that information to make informed decisions about their medical care moving forward. So these are some of my learning objectives. One of my toxic traits is I try to provide maybe too much information in a short period of time. So I know you all have a lot of questions. I'm going to try my best to get through this information so that we can answer questions that you might have. But I'm going to start by providing a general overview of kind of the molecular characteristics of cancer. I want to discuss some of the hereditary risk factors that we do testing for, talk about who should actually consider genetic testing. There are a lot of different genes that you can be tested for. I want to provide some examples of those different genes and how they might actually impact medical management, treatment, screening. I also have a case study that I think will help kind of pull in and illustrate some of the points I'll be talking about. And then lastly, I will try to describe some up-and-coming roles of genomic technologies in cancer care. So I like to start every talk with kind of a basic 101, so starting at the very beginning. So this might seem very, very basic, but what is cancer? So cancer is a very broad term for a class of diseases characterized by abnormal cells that grow and invade healthy cells in the body. So cancer does not just happen overnight. It truly is a multi-step process, sometimes could be years in the making. So within our bodies, we all have trillions of cells. Our cells are constantly dividing, rejuvenating, growing, and sometimes there is a cell that kind of goes rogue. It might acquire some kind of mutations through DNA damage, and we've got a lot of different internal mechanisms in our body that our body should be able to detect that a cell isn't right and potentially kill that cell off before it continues to divide. That's what this very simplistic infographic is trying to show. So one of the cells has acquired a mutation, some DNA damage, and unfortunately the body didn't detect it, so it goes on to divide with that DNA damage. And as it does so, these damaged cells will continue to acquire more and more mutations, and these groups of cells, they will now act differently than the healthy cells in the body. They grow more they grow more quickly. They are escaping some of the internal and external controls on cell division. They're avoiding that programmed cell death, and all of a sudden you're getting a tumor forming. So because of that, we say that all cancers are genetic, but that does not mean that all cancers are inherited. So there is a distinction between those terms, which I hope I'll be able to clarify a little bit more. When I am seeing patients, really the question that I get probably most often, how often are we actually finding that somebody's cancer is due to a genetic mutation that is running in the family? How often is it this hereditary type, where there's a genetic mutation that's being identified and being passed down from generation to generation? It is actually only about 10% of the time that we are finding something on this testing that is indicating there is a hereditary predisposition in the family. So that number might surprise you a little bit. I think sometimes it's overestimated. You think, well, there's a lot of cancer in the family, it must be genetic. But that's actually not always the case. Vast majority of cancer is considered to be sporadic cancer. This is cancer that just happens randomly or happens by chance. In families with sporadic cancer, we might see 1 or 2 individuals developing cancers, potentially at kind of average ages or typical ages of onset. And we also know that other than genetics, there are other contributions to cancer too. So there are environmental risk factors, there are lifestyle risk factors, so things like smoking can really increase the risk for lung and bladder cancer. Things like sun exposure, lots of sunburns can increase the risk for skin cancer. So there's kind of a whole lot that can contribute to somebody developing cancer. The familial category that you see here as well, I want to make a distinction between what that is. So there are some families where we are seeing more cancer than what we would expect to see just by chance alone. So that might prompt us to order genetic testing. So just for example, there might be a family where 3 brothers have all developed prostate cancer. And so that's going to stick out to anyone. You know, what could be going on, what could be causing that? So that would be a family that we would definitely want to order genetic testing on and see if there's something potentially causing that prostate cancer. Sometimes in those families, we still are not finding that genetic cause. So then we got to think about, you know, what else do we share with family members? Yes, we share genetics, we share our DNA, but we also typically share our environment. So we often grow up in the same area as our family members. You know, we are drinking the same water, breathing the same air. Potentially we have similar lifestyle habits as family members. Maybe we all work, you know, in the same factory or have exposures to similar chemicals. So there can be a lot of different things that could potentially be accounting for that pattern of cancer that's not genetic in nature. But about 10% of the time, we do find one of those genetic mutations that we do think is running in the family. And so who should get genetic testing? You know, how do we know when to order this testing? This list is not exhaustive by any means, but these are some of the things that we think doctors and patients should be aware of when trying to guide patients in terms of who should be thinking about doing testing like this. And if you have some of these things in your family, it does not mean that there's for sure something genetic or hereditary going on. Just means that it might be a test you might want to consider for yourself and family members. So one of the things that we look for, are there multiple people with the same types of cancer in the family? Are we seeing 2 or 3 women with breast cancer in the family? Another risk factor that we're looking for, early age of onset. So how old was somebody when they were diagnosed with cancer? For instance, breast cancer, the average age of diagnosis, usually in somebody's early to mid-60s. If we start seeing people are under the age of 50 with cancer, specifically breast, colon, uterine, that's when we start thinking, could there be something genetic that could be playing a role there that could have caused that person to develop that cancer at a younger age? Bilateral cancer, so cancer in both breasts, or multiple primary cancers. So sometimes we see people who have maybe been diagnosed with something like colon cancer, then maybe 10 years later, something like uterine cancer. So having 2 different cancers can sometimes set off our suspicions about there being a hereditary risk factor in the family. Rare cancer, some of which are listed here. So anytime there is a family history of things like ovarian cancer, pancreatic cancer, male breast cancer, metastatic prostate cancer, triple-negative breast cancer, medullary thyroid cancer, these are all indications for genetic testing as well. Colon polyps, it's totally normal to have a few colon polyps on a colonoscopy. Anytime we start seeing that number get to 10, 20 colon polyps is when we start thinking, could there be a genetic predisposition involved? And then, of course, if you have a family member who has done testing like this and has been identified as having one of these genetic mutations, we know that you could have the chance to have it as well. So that's definitely an indication to do or think about doing genetic testing. So I always let everyone know with this genetic testing, it's not going to detect if you have cancer. What the testing does is it determines if you were born with a hereditary predisposition. So were you born with a genetic risk factor that put you at a higher risk of developing cancer over your lifetime? And if you do have cancer, that could potentially be the explanation for why it did develop. And there are lots of different genes that we can test for. So I think probably most commonly people have heard of genes linked with breast cancer, but there are genes linked with colon cancer, uterine cancer, stomach cancer. You can see some of them on the table here that are listed. And these genes have a wide range of risks. Some of them are on the lower end of the spectrum. They might just double the risk for cancer. Other genes on here might quadruple or even higher, increase the risk significantly for certain types of cancer. And so why would somebody want to know this information? Well, there are things that you and family members can do with that information and with knowing that there could be a risk like that. One of the most common suggestions, if we find something like this, increase surveillance. So how can we tweak somebody's screening protocol to be more individualized, more specific to their risk? Are there additional screens that they could undergo moving forward? Are there risk-reducing surgeries? So things like mastectomies, hysterectomies, having ovaries, uterus removed, things like that could prevent somebody from developing cancer altogether. Sometimes it might qualify you for certain medications or for participation in things like clinical trials or research studies. And this slide here, I know it's a little bit busy looking. I wanted to, so with genetic testing, this area has really exploded in the last decade. There are a lot of different labs that do this testing. There are a lot of different tests out there. This is just an example of what we call a panel. So today, if you're getting genetic testing, you really should be getting tested for more than just the BRCA1 or 2 genes. It used to be pretty commonplace 10 years ago or so to just be tested for 1 or 2 genes that the doctor was the most suspicious for. But now we know of all of these other genes that can potentially be playing a role in the development of cancer and putting you at risk for other cancers. And you can see in the first column, those are the names of some of the genes that we can test for. So these are genes that we all have. I have them, you have them. We all have 2 copies of all of our genes in our body. And these genes specifically are in our bodies to make sure that we don't develop cancer. So they function as tumor suppressor genes, as DNA repair genes. They are in our bodies to make sure that cancer doesn't form. So the test isn't looking to see if you have these genes or if you don't have them. It's actually looking to see, are these genes all working correctly? Are these genes all functioning in the way that they should be and protecting you from cancer? For people who are born with a mutation in one of these genes, there could be a higher risk for the cancers that are indicated in these other columns. And really kind of the take home here is you can see for almost all the genes, there are multiple cancers that they're linked with. And so there's lots of overlap. A lot of the genes linked with breast cancer are also linked with prostate cancer. A lot of the genes linked with colon cancer are also linked with things like uterine and ovarian cancer. So there can be a lot of different information from this one test that you can gather. Potentially it could shed some light on your cancer diagnosis, but could also give you more information about risk moving forward. What is the chance that this could happen again? Or what is the chance for a different type of cancer to happen? And I wanted to provide some specific examples for what we would actually recommend if we were to find mutations like this. And these are just examples, but we know that there is general population screening guidelines out there for things like breast, colon, and prostate cancer. Now, if we were to identify a genetic mutation where we think somebody's now at high risk, again, how can we tweak what the general population is doing to better assess your risk? And some of this information depends on if you have cancer when you're being tested, if you don't have cancer, how old you are. But just to provide an example, so let's say we find a mutation in a gene linked with breast cancer. That might mean that we're going to recommend, instead of waiting until you're 40 to start annual mammograms, we might recommend that a young woman start at 25 or 30 doing this type of screening. Women who are at a higher risk for breast cancer, we also recommend breast MRIs. So again, that's not something that people in the general population are typically getting. It's considered like an enhanced screening technology. And we recommend anyone who has a higher risk for breast cancer also get those breast MRIs. And it's not that we recommend in the same day getting the mammogram and MRI. It's actually like a 6-month, alternating every 6 months, getting one or the other. So these women at a higher risk, they're getting screened earlier. They're getting screened twice a year instead of once a year. And they're also using 2 different ways to look at the breast tissue instead of just the mammogram alone. So again, the goal with something like this is we can't prevent a cancer from forming, but potentially detecting it at an earlier and more treatable stage. Sometimes I see women who are in their breast cancer journey, and they might be deciding about a surgery. So that is another way where genetic information can come into play. Some women want to know if there is some kind of genetic mutation that caused their breast cancer, because sometimes we can learn it could be putting them at a higher risk to develop another breast cancer within 5 or 10 years. For some women, that might play a role in their surgery, whether it be lumpectomy, double mastectomy, trying to figure out what kind of action they want to take moving forward. Similarly, for colon cancer, we know general population screening, 45 every 10 years typically. If there's a genetic mutation, we might recommend as early as 25 or 30, maybe even getting them done every 1 to 2 years. Again, if somebody has colon cancer and there's a genetic mutation behind it, it might mean that they should consider that in their surgery, and potentially a more extensive surgery might be recommended. Prostate cancer screening, again, earlier prostate cancer screening for those who have one of these hereditary risk factors, potentially starting at 35 instead of waiting until 45. And then there's a whole host of cancers that this type of testing could pick up a risk for that general population doesn't get screening for at all. So things like ovarian and uterine cancer. These are 2 areas we actually don't have great screening for, but for women who have a higher risk, we might recommend things like transvaginal ultrasounds or CA-125 tests when somebody's in their 30s. Ultimately, because there's not great screening for these cancers, we end up recommending that they consider a hysterectomy or having their ovaries removed when they are 35 and older and done having children. So the idea behind that surgery is hopefully that person could prevent themselves from developing that cancer altogether, because ovarian and uterine cancer are very hard to detect. Pancreatic cancer screening might be recommended. Endoscopic ultrasounds, MRIs for those individuals who have a higher risk. Thyroid cancer risk, thyroid ultrasounds once a year. So these are things that not only through a genetic test might be recommended, but also through family history. So if you have a family history of some of these cancers, these types of things could be recommended to you really regardless of genetic testing results. Okay, and I do have a case example that I wanted to just walk through just to kind of highlight some of this information. You can see that there is, and this is called a pedigree. It's a family tree. Anyone who sees a genetic counselor will be familiar with this kind of image. It is a family tree that is generated for you specifically if you see a genetic counselor. It looks to evaluate patterns of cancer in the family. So in this example, the individual that came to see me is actually Lucy, the 38-year-old. You can see the little arrow pointed to her. She doesn't have cancer, but she came because there was a family history of cancer. So she reported her sister had breast cancer at 39. Her mother passed away from ovarian cancer at 52. Maternal aunt with breast cancer, maternal uncle with prostate cancer, maternal grandmother with a female cancer at a young age. So when I see this as a genetic counselor, I'm becoming very suspicious. Hey, there's a lot of those red flags that we talked about that are popping up in this family. It certainly looks suspicious, not meaning that we're for sure going to find something, but certainly makes sense for somebody in this situation to consider genetic testing. Now, the other thing we want to consider is who should actually get genetic testing in a family. Usually the person who is most informative to do a genetic test is the person who actually is affected with cancer. So they are the person that is going to be most likely, if there is a genetic mutation in the family, to have it. And then from that, then other family members that don't have cancer can start to get testing and have that kind of specific guideline conversation with their doctor. So in talking with this patient, she said, oh, my sister is getting genetic testing. She should have her results soon. I said, great, let's wait to see what happens there, and then we can make a plan for you. So I meet with this patient again. She tells me, yes, my sister and my maternal aunt both tested positive for a mutation in the BRCA1 gene. So you might have heard of any of the genes. I think BRCA1 and BRCA2, probably the most commonly referenced. So you've probably heard of those, if any. These are genes linked with breast and ovarian cancer, as well as male breast cancer, prostate cancer, pancreatic cancer, and even melanoma. So this table here is trying to show you the actual risk if somebody had a mutation like that. In gray, that is the general population risk. In pink, that is the risk if you had a mutation like this. So again, for breast and ovarian cancer, very, very high risk. And different things that we can recommend to people who have a mutation like this to hopefully help reduce their risk moving forward. We know if somebody has a genetic mutation like this, there is a 50-50 chance that their children could have it, and a 50-50 chance that their siblings could have it. So for the patient Lucy who came in, we know her sister has it, and now she has a 50-50 chance to have the same mutation. So, of course, she does testing. She's found to have the same mutation as her sister. We reassure her this does not mean that you're going to get cancer. It just means you have these higher risks. Here are the things you can consider. We recommend that she consider enhanced breast cancer screening. So instead of waiting until she's 40 for those mammograms, starting now, adding in the breast MRI at that 6-month interval. She also has the option for a double mastectomy if that's something that she feels like she would like to pursue to reduce her risk altogether. We also recommend to patients like this that they consider having their ovaries removed if they are over the age of 35 and done having children. Again, like we talked about before, very hard cancer to detect at an early stage. So those are the main recommendations for a patient like this who has a mutation showing that high risk. And we also don't want to forget about the brother in this scenario. So you can see there's a brother, Brad, who's 42. Sometimes I think males get left out of the conversation a little bit when it comes to genetic testing. There's so much focus on the breast and ovarian cancer risk. Meanwhile, these genes can increase the risk for male breast cancer, prostate cancer, pancreatic cancer. And so it's really important for this individual, he's got young daughters too, to know if he carries that mutation. He also has the 50-50 chance. Luckily for him, he tests negative, so we know that him and his children are not at risk. These mutations do not skip generations. So if somebody tests negative, their children would not have that mutation. The only way the children could have it would be if it happened to come from the other side of the family. So I always like to highlight that because I think there sometimes is a misconception about the skipping of generations, but these genes do not skip generations. Okay, so who orders genetic testing? It can be ordered through your doctor or a genetic counselor like myself. I hope I've illustrated today that it really is more than a blood draw. I want you to think of it as more than that. It really should be a conversation between you and your healthcare provider about your family history and how this information could impact you specifically and your relatives. So genetic counselors, we have advanced training in medical genetics and counseling, and we're really there to help guide you. If you meet with a genetic counselor, it does not mean that you have to do genetic testing. It's really just a conversation so we can answer your questions, provide information, and then if it feels like it's right for you, we can go ahead and order the testing and help with those next steps. Okay, and then hopefully I'm doing okay on time, but yeah, okay. Yep, no, I'm wrapping up. So the last thing I wanted to kind of highlight is tumor genetic testing. So this is a different type of genetic testing than what I've been talking about today. So the testing that we're talking about today is the type of testing you can do through a blood draw or a saliva, looking for, again, inherited changes that you were born with that are predisposing somebody to cancer. Tumor genetic testing is different. This is testing that could be ordered through your doctor, and it is done on patients who have specific types of cancer, and it's usually done through a tumor biopsy or a surgical specimen. And this type of testing is really great and has huge potential. The goals of the testing differ though. It is really used to help identify some targetable acquired mutations. So knowing about the molecular composition of a tumor, no matter where it is, it can tell the doctor so much about how that cancer might behave and how that cancer might respond to certain treatments like chemotherapies and immunotherapies. It can really be used as a roadmap. So remember we said at the very beginning, all cancer is genetic, but that doesn't mean all cancer is inherited. So looking at somebody's specific tumor can really help a doctor make some of those decisions. It can help aid them in, number one, even making the diagnosis to begin with. It can help be used for treatment, for evaluation of prognosis, how is somebody responding to treatment, and it can also help somebody become eligible for certain clinical trials. So a really important test. It's not necessarily indicated for every person who has cancer, but your doctor will certainly talk with you about if it's something that would be beneficial, in your particular case. Okay, so just kind of in summary, wrapping up, genetic testing can really be extremely useful for not only you, but for family members. It helps identify people who have a higher risk for certain types of cancer so that you can take a more personalized approach to your medical management and surveillance. It's got potential for the entire family. And genetic counselors are here to help patients go through this information, go through their options, and help facilitate the most appropriate testing for you. Our service at Karmanos, I'm part of a team. I've got all my team members up here. We are at lots of different McLaren locations. So Flint, Lansing, those are two of the sites that we serve. You can see some of the other ones listed here. We do virtual sessions at lots of the McLaren sites, but there is the option for in-person genetic counseling at both Detroit and Weisberg. So if you want more information, we've got a really great webpage. I know somebody was asking earlier about where can I find information like this. On the Karmanos webpage, and especially our genetics webpage, we have a ton of resources on that webpage that can help educate you if this is information you're interested in. Awesome. So that was my talk, and I'm happy to take any questions. Thank you, guys.